To all gathered here. So this IC battering corneal emergencies is curated to highlight the basic aspects of dealing with the various kind of emergencies in cornea that we see in our day-to-day practice. So for this, we have a team of experts who will be speaking on the same. So today I'll be starting on a stitch in time, corneal tear repair. So we all know that ocular injury is classified as closed globe and open globe. In open globe, we have two types, penetrating and perforating. So what is the difference? Penetrating is when you have a partial thickness wound with an entry wound but no exit wound, and perforating is, can you see the slides?
Yeah.
Yeah. So in perforating, you have a full thickness wound with an entry and an exit wound. So here you have more chances of having an intraocular foreign body, infection, etc. And this requires immediate intervention. So how do we assess the patient? We have to ask for the history of injury, the time of injury, the nature of injury. That will give us a clue about any organic material or metallic IOFB. Documenting the visual acuity is very important. We have to check for the perception of light, assess the color vision, the pupil, and the extraocular movements. On slit lamp, we have to assess the extent of the corneal tear, the site, the size, involvement of limbus, and sclera. Presence of iris prolapse, ruptured lens capsule, any loose cortex in the AC, subluxated lens, or cataractous lens has to be assessed. Presence of hypopyon can give us a sign as an indication of endophthalmitis, and we have to look for a presence of an intraocular foreign body. So fluorescein staining is again crucial. You might have just a simple epithelial defect, or we might have a Seedl's positive, as we can see here, where your fluorescein gets diluted by the oozing aqueous. If your Seedl's is negative, do a forced Seedl's test by applying gentle pressure at the limbus over the eyelid and look for a small leak. If you have an obvious laceration with an iris prolapse, there is no indication to stain, as it won't give you any additional information. So immediate care, it's preferable to admit the patient, check for the fasting status, give a booster dose of injection tetanus toxoid, start a broad spectrum IV antibiotic, oral analgesia. It's preferable to patch the eye using an eye shield, and we have to avoid applying any eye drops or ointments in an open globe. So imaging again is crucial if you have a suspicion of an intraocular foreign body. So X-ray can be done, but it's only for metallic foreign bodies. CT orbit is ideal. We can ask for sagittal and coronal sections with thin slices, although this can miss plastic or wood intraocular foreign bodies. MRI might not be suitable for metallic objects, as the magnetic force can distort the object. A B-scan ultrasound also preferable to avoid when you have an open globe to avoid undue pressure. An anterior segment OCT can give you an idea of the depth of the laceration, but for IOFB, only something in the anterior chamber can be visualized because of the poor penetration. So here you have an illustration of a corneal tear with a metallic wire which was imaged in a CT scan. This has traversed the lens capsule as well. And here you have a B-scan image where you have a foreign body with a high spike and corresponding back shadowing, so probably a metallic foreign body. So do all corneal tears need to be sutured? So it depends on the type of injury. If it is a perforating or a full thickness tear, you have Seedl's positive, a flat chamber with active leak, a soft eye with iris prolapse, yes, it is mandatory to take up the patient. If you have a penetrating injury, which is a smaller wound of less than 2 mm, less than 50% of corneal thickness, away from visual axis with no surrounding edema, it can be observed by placing a bandage contact lens and starting lubricants and antibiotics. But a larger wound with a depth of more than 50% involving the visual axis, stellate, fine tears, or in a pediatric age group, we have to suture them. So time of suturing is ideally as soon as possible because the risk of endophthalmitis increases with time, although a short delay is still preferred to improper management or suturing. So what are the goals of suturing? We want to make the wound watertight, we want to minimize scarring, we want to reduce the astigmatism and provide visual rehabilitation and reduce the risk of infection. So we prefer general anesthesia, especially in children. If it is not possible, we can give a very cautious peribulbar anesthesia. We have to avoid topical proparacaine in an open globe injury. While placing a speculum, try to avoid undue pressure on the globe, avoid the surface antiseptic like povidone, and we can just irrigate the surface with balanced salt solution to remove the debris and contaminants. Once that is done, the size and the morphology of the wound is assessed. So what sutures do we prefer? If it's a corneal tear, we prefer a monofilament 10O nylon, for the limbus 9O, for sclera 8O, nylon or vicryl, and for stellate or very minute tears, we can use 11O nylon. If you have iris prolapse like this, it's preferable to make a side port incision away from the edge of the wound and inject viscoelastic or air through that. And we can gently use a spatula and sweep the iris away from the wound. It's preferable not to manipulate the iris through the wound itself. If you have iris at the wound but is not exited the wound, we can just gently reposit it back. But if iris has prolapsed out for more than 24 hours, it's preferable to abscise the iris to prevent introduction of surface epithelium or infection. So what are ideal sutures? They should be perpendicular to the wound at 90% depth and equidistant from the anterior edge of the wound. If you have a shelved wound like this, it's preferable to keep it equidistant to the endothelial side. And remember to bury all knots. So what should we avoid? Unequal wound bites like this can cause overriding. Shallow sutures can cause a posterior wound gape, and this will lead to aqueous getting exposed to the stroma and causing edema. And a full thickness suture, of course, is a pathway for microbial invasion. So every suture works via tissue compression. So every suture has a zone of compression which is closest at the plane itself, and then it gradually fades away. So ideally, two adjacent compression zones should overlap. If you have something like this where the zones don't overlap, there can be a wound leak. So when you have a corneoscleral wound involving the limbus, the first suture is preferably placed at the limbus for anatomical restoration, and then we suture the cornea and then move on to the sclera. When you have a linear corneal wound, we start from the two peripheries with long bites. The bites get progressively shorter towards the center. So at the periphery, your bites are longer, a little more tight, and a little more deep to flatten the periphery. At the center, they must be shorter, less tight, and less deep to steepen the center. We can try to avoid a suture just at the apex of the cornea. So when you have an angular corneal wound like this, we can place the first bite at the angle itself, divide that into multiple linear wounds, and then start at the periphery and move towards the center. When you have stellate tears, these are a bit difficult to manage, so a purse string suture can be applied. For this, we can use 11O nylon, and once your suturing is complete, we can check for wound leak by using a Seidels test or check with air or saline. So wound gaping, of course, can occur when your compression zones don't overlap. So that can be removed by placing an additional suture, tightening the existing suture, or taking sutures with longer bites. We can also place a drop of cyanoacrylate glue or a bandage contact lens along with that. But this we try to avoid when it's at the visual axis because they tend to invite scarring. So management of lens, if you have a ruptured lens capsule, your options are suture the primary wound, and then you can either defer the lensectomy, you can do a lensectomy and leave the eye aphakic, or you can remove the cataract and place an IOL. But this is of course avoided when you have a suspicion of infection. So this will again depend on the surgeon's expertise, but ideally we don't want to leave loose fluffy cortical matter in the anterior chamber. At the same time, we want to preserve the posterior capsule as much as possible. So post-operatively, we start the patient on antimicrobials, we start topical steroids, and for IOP control. So medical legal considerations, again, is very important. We have to clearly explain the visual prognosis, the need for multiple procedures in future, and it's preferable to always have your pre and post-treatment photos documented. Suture removal for adults is done between 3 and 6 months, and for children, it's much earlier, 1 to 2 months. While removing sutures, we try to cut the suture away from the knot and remove it like this. In that way, the knot doesn't traverse through the stroma. So once your sutures are removed for visual rehabilitation, we can either provide spectacles or contact lenses and RGP. If it's a superficial scar, we can remove it by PTK. If it's a much denser scar, we can either do a lamellar or penetrating keratoplasty or an optical iridectomy. And of course, we have to manage the cataract. Thank you.